awareness about cancer and to help patients and caregivers access the right treatment at the right time. Breast cancer treatment has entered a new era where even very low levels of HER2 expression are becoming clinically meaningful. Traditionally, tumors were classified simply as HER2 positive or HER2 negative, but emerging research has identified new subgroups and the recently explored HER2-Ultra-Low and low disease. These categories are reshaping how we think about targeted therapy, particularly with the advent of the ADCs or the antibody drug conjugates. In this session, we'll explore how these new classifications are defined, the clinical relevance, and what they mean for the future of breast cancer treatment. Joining us today is Dr. Krishnamani, a highly respected leader in the field of oncology. For over a decade at AOI Hospitals, Hyderabad, he has been at the forefront of cancer, bringing deep expertise in the management of solid tumors, hematological malignancies, and oncological emergencies. His professional journey includes prestigious international fellowships and key leadership roles across some of India's leading cancer centers, reflecting a truly global outlook combined with strong clinical excellence. Beyond patient care, he has played an important role in advancing oncology practice, contributing to treatment protocols, supporting research initiatives, and helping shape cancer care frameworks. What truly distinguishes him, however, is his compassionate, patient first philosophy. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And today, as you said, let's talk about HER2-low and ultra-low breast cancer.
So, sir, we already know a little background about the HER2 disease. But, sir, can you tell us what the traditional classification of HER2 disease was and how it has evolved now?
So first, what we should understand is in the treatment of breast cancer, all the stages across stage 1, 2, 3, and 4, we use three parameters called ER, estrogen receptor, PR, progesterone receptor, and HER2 receptor. Whether it is positive or negative decides number one, the nature of the disease. Hormone positive, ER/PR positive, HER2 negative is a good disease. Triple negative, ER/PR, HER2, all negative is a bad disease, is an aggressive disease, has a risk of coming back. So your ER/PR, HER2 has to be done on every breast cancer across the stages. It tells you whether you're hormone positive. If you're hormone positive, HER2 negative, it's a good disease. Triple negative, the risk of recurrence is higher. It also tells you what treatment you should get. If you are hormone positive, you will get hormonal therapy also. You may get chemotherapy. That is for a different discussion. But anybody who is estrogen receptor, progesterone receptor positive should receive hormonal therapy in all the stages. Anybody is HER2 positive receives targeted therapy. The names of the medicines are trastuzumab, pertuzumab, etc. Now, today we'll concentrate on HER2 positive. HER2 positive means on the tumor, you do a scoring. It is done by a method called IHC, immunohistochemistry. Okay, if on immunohistochemistry on the tumor, the score comes as 0, you are HER2 negative. If it comes as 1, you are HER2 negative. If it comes as 3, you are HER2 positive. So HER2 testing has to be done on the tumor. If your score is 0 or 1, you are negative. If you are 3, you are positive. If you are HER2-2, you are neither negative, neither positive. So for HER2-2 patients, by IHC, you do an additional test called FISH or DISH. FISH or DISH. Okay, it is called fluorescence in situ hybridization. So all HER2-2 plus do FISH. If you are FISH positive, you become HER2 positive. If you're FISH negative, you are HER2 negative. So the traditional classification is HER2 negative, HER2 positive. HER2 negative is 0, 1 and 2 FISH negative. HER2 positive is 3 and 2 FISH positive. So 0, 1 negative, 3 positive, 2 FISH negative is negative, FISH positive is HER2 positive. This is your classification. Now, you are looking at not only HER2 negative, HER2 positive, there is a big group called HER2-low, HER2-ultra-low. Okay, so HER2-1 and 2 fish negative are low. So in that HER2 negative group, why are you doing all this? In the HER2 negative group, there are some people who will respond to this HER2 therapy, targeted therapy. So now because you say they are negative, you're not giving them those medicines and they are losing out on the benefit. So researchers have identified that there is a HER2 negative group which will benefit with HER2 positive treatment, that is targeted therapy. In that HER2 negative, the low group that is divided into low and ultra low. Low means HER2-1, HER2-2 fish negative. Ultra low is below low. What is below 1? 0. HER2 0 with some membranous staining, 10%. So now if you look at HER2, HER2 0 is 1, HER2 ultra low, that is 0 with some membranous staining. Then HER2 1 and 2 fish negative, that is HER2 low. So HER2 0, HER2 ultra low, HER2 low. Then you have HER2 positive. Why? Because you want to use the HER2 positive medicines in these two groups also. These people will also get maximum benefit. Otherwise, in this group, at a point, we were always saying, no, 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 you cannot get HER2 therapy. You should only receive some form of chemotherapy, and chemotherapy side effects and their survival used to be limited.
Sir, how common are these groups like the HER2 ultra low and the HER2 low? How common are they diagnosed among the Indian women?
So HER2 low will be close to 50 to 60%. HER2 ultra low will be another 15 to 25%.
Sir, is it differentiated into specific subtypes such as ERBR positive or ERBR positive HER2 ultra low?
Correct.
And
So that is separate ERPR. In the HER2, you are dividing into ultra low, low, HER2 positive.
sir, when we talk about the clinical symptoms of these patients, do they have any peculiar clinical symptoms which are not seen in the HER2 positive group and not seen in the HER2 negative group?
So the HER2 ultra low patients, they have less amount of ERPR positivity compared to the HER2 low patients. So they have more amount of resistant disease. They behave more like sometimes like a triple negative disease.
Sir, with bringing in this new classification of including HER2 low and HER2 ultra low, what were the gaps that they were trying to fill in? What
So
were
the
the
main
needs that
gap
they
is,
sought?
see, why have they all done this? You are looking at stage 4 cancer, disease progresses, it comes back again and again. What were you doing in the HER2 negative group or the low ultra low group earlier? You will say no targeted therapy, so that is out of the question. You will, if you are hormone negative, then hormone therapy is not there. If you are hormone positive, after 2 lines or 3 lines, you don't have hormonal medicines. So you were constantly hitting your patients with chemotherapy, and each time you go to a new chemotherapy, the responses keep coming down, the survival keeps coming down. So the first time you in hormone positive disease also, if your medicines, your palbociclib, CDK4 inhibitors with anastrozole works for 2.5 years, when it comes to second line, it comes down to 9 months, and in third line, it comes down to hardly 3 months. So you want to extend the survival with good quality of life, avoid chemotherapy, and try to use a targeted agent in this select group of patients.
Sir, can you elaborate a little bit on the treatment part? Like, how do you classify the patients and what type of treatments you would give
So
to
I'll
these
give you the
patients?
background. It is more like, so there was a trial called the Destiny trial. In the Destiny trial, they looked at a drug called trastuzumab deruxtecan. Okay, or to put it in simple words, TDXD. So I will give you a background of this drug first. So TDXD was first used in stage 4 HER2 positive patients. After they failed multiple HER2 medicines like pertuzumab, trastuzumab, TDM1, etc. Then they compared TDXD with TDM1 and they said TDXD is better. So TDXD becomes a second line. First, it was used after Per2 Tras2, after TDM1. Then they compared TDM1, TDXD with TDM1, and they said this is much better, so use it. Now there is a trial which says TDXD is better than Per2 Tras2 combination also to be used in first line. This is all in HER2 positive patients, stage 4. So name of the drug is trastuzumab deruxtecan. This drug trial is called Destiny trial. Destiny 1, Destiny 4, Destiny 6, Destiny 9. So in the HER2 low ultra low means you are coming in the HER2 negative group. Till now we spoke about HER2 positive. You are coming here, this side, left side now. When you are coming there, they have used the same drug. They first used it in a trial called Destiny 4, where HER2 low patients who received chemotherapy, they used the drug. They compared it with another chemotherapy and they found this is beneficial. And it was beneficial both in hormone positive and hormone negative. So, what did they prove? You are using it in HER2 negative population, that is HER2 low population, in patients who received prior chemo. And it is better than chemo, new chemo. Now, the next trial came, Destiny 6. They were like, here you used low, we will use it in ultra low also. So they are going even further. And why they used it in patients who never received chemo before and hormone positive group only. So Destiny 6 was both hormone positive, HER2 negative. Destiny 4. Destiny 6 is only hormone positive. Here patients had received lot of chemo before, here no chemo before. Here only low, here low and ultra low. So you are shifting it from HER2 positive to HER2 low to even HER2 ultra low to all hormone positive negative to only hormone positive, and the new group of patients have not received chemo also. That means you want to use your best drug in the beginning itself. And they found that it had a good progression free survival. That is the time you are alive without progression of the disease. That is why today it is recommended in both HER2-low, in HER2-Ultra-low, those who received chemotherapy, or in hormone positive who have failed at least 2 lines of endocrine therapy, which includes anastrozole, palbociclib, and fulvestrant or something else.
Sir, besides TDXD, are there any other drugs which are coming up for these classification of the patients?
There is a drug called daptomab deruxtecan. Then there is another drug which is like TDXD, which is called sacituzumab, which is used in triple negative breast cancer, not in the exactly in the HER2-low setting, triple negative breast cancer, where it has shown improved survival. Daptomab has shown improvement compared to chemotherapy alone in hormone positive HER2 negative patients. So these are the few drugs. But the main drug is TDXD.
Sir, looking ahead, do you think that HER2 expression could be viewed more as a spectrum rather than just two classifications?
Correct. So now we don't classify it as negative and positive. You should give it as ultra low, low, and HER2 positive. That is how you have to classify.
Sir, is there a chance that during the life cycle of the disease in one patient, the patient can go from being HER2 positive at one point, HER2 ultra low, to completely HER2 negative disease? Is there a chance for the spectrum to happen?
15 to 25% of patients, their hormone and HER2 status may change when they develop metastatic disease. That is why if a patient was treated initially for early stage and now she comes as stage 4 disease, rebiopsy and please recheck the hormone and HER2 positive status. Generally, hormone positive goes to bones, HER2 positive goes to brain, triple negative will have skin nodules. But if you were treated earlier, now you come back with stage 4, rebiopsy, because 15 to 20, 25% of patients, hormone positive can become negative, or negative can become positive, or HER2 positive negative, vice versa.
Sir, is this clinical scenario applicable for the early breast cancer patients as well, or is it more relevant only for patients with in the metastatic setting?
So that means when you were treated for early breast cancer, suppose you are HER2 negative and hormone positive, when you develop metastatic disease, recheck. You may become HER2 positive, but again, only 15%, 85% will still be the same, but do check. Now we have a lady, I still remember, stage 4 breast cancer, day 1, hormone positive, HER2 negative. We have put her on hormonal therapy with palbociclib, did well for 3 years, then progressed. Then we put her on a drug called hormonal drug called fulvestrant. We discussed that last time, elacestrant, fulvestrant. But fulvestrant didn't work very long for her. So the first drug worked for 3 years. So I'm expecting fulvestrant to work at least for 9 to 15 months. It didn't work. It worked within 3 months. She progressed. That is when you should suspect endocrine resistance. Your treatment is getting resistant. So we rebiopsied. Now she becomes triple negative. HER2 negative, which is already there, ERPR negative. Then you should do something called PDL1 score. The PDL1 score is more than 10. So we put her on chemotherapy plus immunotherapy, pembrolizumab. So much has changed. Otherwise, blindly, we would have given exemestane, everolimus, or tamoxifen, or other kind of hormonal medicines which would have never worked for her.
Sir, if you could just briefly summarize how clinicians should approach for this classification along with the treatment for the breast cancer patients.
So right now, all of us should understand that there is HER2 negative, HER2 positive concept is gone. Either you are HER2 positive or low or ultra low. Low and ultra low patients do benefit from targeted therapy, which is trastuzumab deruxtecan. It is better than chemotherapy in prolonging their survival without progression of disease. That is what we should understand.
Sir, what message would you like to give to our viewers regarding today's session?
So today's session, please understand the tre- there are a lot of targeted therapies, and not only in the HER2 positive space, also in the so-called HER2 negative or low, ultra low space. So get your pathologist checked for HER2 low and ultra low. As you said, HER2 profiling can change, or even hormonal profiling over a period of time. So get rebiopsied if you have endocrine resistance. Trastuzumab deruxtecan is available in India. You give it once every 3 weeks, works in these settings, both in hormone positive or negative. You can use it in patients who received chemo or never received chemo also, based on Destiny 4 and 6, and it works better than chemo.
So, can you tell us a little bit about the second opinion campaign which is being run by you?
So, as we all know, we have a second opinion campaign. A WhatsApp number is shared. People can send their reports on WhatsApp and we will get back to them. This is to create awareness and help them get a structured opinion. Um, it is not to dissuade you from meeting your doctor and all that. It is more intended for patients in rural areas where they don't have facilities to meet an oncologist, or who want to have an idea. So based on a report alone, we cannot say everything, but we will try to at least guide our patients.
Thank you for enlightening us with today's session, sir. We hope to see you again next week with another important topic to discuss. Thank you, sir.
Thank you so much.